69 years old and I have heart disease, high blood pressure, and incurable fast-growing prostate cancer. I have a couple of other chronic conditions and special concerns as a transgender person, and in addition, I'm allergic to some of the drugs that would most be used to treat my conditions. I'm actually doing the wise things for myself and am still productive in several ways. One of the big reasons for my sustained good health is my primary care physician, Dr. Gail Povar. In addition to being a good doctor, she is an outstanding advocate in coordinating for my sometimes complex care. I believe significantly more money can be saved in Medicare by directing more resources to primary physicians for coordination and patient advocacy and less to the complex organizational programs that have the same purpose. Instead of buying expensive football teams, what we need is more archers.
Well, let me, I'm not going to comment on football because are most people around here Ravens fans or Redskins fans? I mean, I'm just not sure. I just wanted to make sure, you know, I don't know. See, this is why I didn't want to talk about football. And we got a Navy person here. This issue of primary care physicians is absolutely critical. And it has the promise of making such a big difference in the overall health of everybody, from children to seniors. It used to be that most of us had a family doctor. You would consult with that family doctor. They knew your history. They knew your family. They knew your children. That they helped deliver babies. And as a consequence, what happened is that everybody got regular checkups and could anticipate a lot of the problems that are out there. Now, in these big medical systems, so often what happens is that you're shuttled around from specialist to specialist. Oftentimes, people don't have a primary care physician that they're comfortable with, so they don't get regular checkups. They don't get regular consultations. Preventable diseases end up being missed. And you don't have the kind of coordination that's necessary between all these different specialists, right? So you go to one doctor, they take a test, then you go to the hospital, they have you take the same test. A lot of errors occur because there's not communications between these various specialists, and it adds a lot of cost because each time that test is being taken, they're charging Medicare if you're on Medicare, and if you're not on Medicare, they're charging the insurance company, and that is part of what is adding to all these costs. So what we've been trying to do, and this was a major focus of the health reform bill, is how do we get more primary physicians, number one, and number two, how do we give them more power so that they are the hub around which a patient-centered the medical system exists, right? And first step is getting more primary care physicians. I mean, sadly, a lot of young medical students, they'd love to go into primary care, but primary care physicians don't get paid as well as specialists. So they say to themselves, you know what, I don't want to, I've got all these medical school bills that I got to pay. I've got to become a plastic surgeon or something. And so part of the bill was to, through loan forgiveness programs and other mechanisms, make it more enticing for young medical students to go into primary care, build up the pool of primary care physicians. Number two is increasing the reimbursements for primary care. You know, right now you've got a situation where if a primary care physician says to a patient, you know what, you need to lose some weight because you're at risk of diabetes, and I've got a good, you know, exercise program that makes sense, and here's a dietitian that you should talk to. Sometimes Medicare may not reimburse that consultation, but they'll reimburse the $30,000 foot amputation because after somebody gets the disease. Well, that doesn't make sense. So changing our reimbursement system to encourage preventive care and encourage what primary care physicians do is probably going to be the single most important thing that we can do to assure that you and those of you who have good primary care physicians continue to get that kind of care. Last point I'll make, and I just want to go back to this point that I made during my remarks. About a decade ago, I guess, and Barbara, correct me if I'm getting the timing wrong, but about a decade ago, Congress, not our Congress, but previous Congress, made the decision that the way we were going to actually cut Medicare, or cut the rising costs of Medicare, was to say to doctors and providers, we're going to cap you at a certain level, and if you don't, tough luck. And in theory it sounded good, but it wasn't very well thought through. And so what happened was each year costs for doctors went up and the reimbursements didn't. And eventually it got so bad that Congress then started saying, you know what, this isn't realistic. So each year they'd kind of do a patchwork fix on this thing. And the formula for reimbursing Medicare doctors would be adjusted, but it would only be adjusted for a year or adjusted for 2 years. But it wouldn't get adjusted permanently. And what's happened is over time it's built up so that now each year you end up having this emergency where unless Congress passes a bill right away, suddenly Medicare doctors are going to get a 21% cut in their reimbursements because all that healthcare inflation had built up over time. Well, we're now in this situation again. And we've got to fix this permanently. Now, in the meantime, temporarily, we've got to make sure that your doctor is getting reimbursed so that they can stay in business and keep their doors open. And my administration has worked very closely with doctors to try to see if we can get this fixed short term, but ultimately we're going to have to get it fixed long term. What we want is a system where doctors are reimbursed for the right things. We want them reimbursed for quality. We want them reimbursed for how good care you can get, you're giving patients. We don't want doctors just to be reimbursed for how many tests they do or how many procedures they do, because sometimes that may mean that they're not given the best care. We want quality, not quantity. So there are adjustments we need to make over the long term in how we reimburse doctors, but what we shouldn't do is have this, guillotine hanging over their heads every year where they're having to figure out, am I going to get reimbursed or is suddenly my income going to drop by 20%? Because what will happen is more and more people will say, I don't want to be a Medicare doctor. I don't want to be a primary care physician for somebody on Medicare because it's going to make my income unstable. That's something that we've got to fix.